we're going to start with our Community Voices panel, and I'd like to introduce everybody. We have Phyllis, Marsh, Jarvis, to my right, community leader, executive member, and Cape Breton lead of the Health Association of African Nova Scotians. Debbie Boy Crowther, to my left, Director of Family and Community Healing Program, Mi'kmaq Family and Children's Services of Nova Scotia. Judy Hughes, to my far left, Crisis Intervention Counselor with Tierman Transition House. Jeannie Rokosh, to my far right, Manager, Office of Diversity and Inclusion, Nova Scotia Community College, Leeds Campus. And Marie-Claude Rioux, Executive Director, Réseau Santé Nouvelle-Écosse, in the middle to my left. So we will start. Tabinda Sheik is unable to be with us. She left me with her presentation, so I'll be reading that on her behalf as well. So we will start, just to make it easy, to my far right, we'll start with Jeannie Rokosh for 5 minutes. Actually, what I'll do first, sorry, I'll set this up a little bit. What we did to help the presenters with the remarks, we gave them 3 questions. So they're each going to have 5 minutes to speak to those questions. We're going to have a question and answer period, and then they will each have 2 minutes to provide any closing remarks or any other remarks that they'd like to make. The 3 questions: what is your connection to domestic violence? From your perspective, what factors contribute to domestic violence? And in situations of domestic violence, what barriers do people experience in seeking and using support or health services? So we'll start with Jeannie.
So what is my connection to domestic violence? Throughout my career, I think I've had touch points of connection, more so as an addictions counselor a number of years ago, and recently, prior to my work at NSCC, as the coordinator of Pride Health, which is a program, for those of you that don't know, that is providing better access to health care for the gay, lesbian, bisexual, trans, intersex, and don't ask me to say it again, community. And don't ask what the right words are, because they'll change by the time we leave. So that's kind of my connection around the issue. The second question, from my perspective, what factors contribute? Well, in the gay community, which is sometimes an overarching term for all of those acronyms, probably what's significant is people's lack of understanding or validation of a relationship and the possibility that there would be domestic violence. So case in point might be 2 men in a partnership and there being some sort of a conflict or some kind of domestic violence, and them being told that, well, you know, men fight anyway, like, so you guys were just fighting. That might be one example. So the other piece I think about is I think about gender, and I think about the continuum of gender. We have specifically male, we have specifically female, we have shelters based on those 2 areas. The barrier becomes, if you are perhaps transitioning as a person who's transgender, which shelter do you go to? You may create discomfort, not because you're you, but because people are uncomfortable with your identity or your identification. So the actual shelter system, and that's not a criticism of the shelter system, because the shelter system is brilliant. It's just a comment on how do we look between those gender binary pieces and go, where do trans people go? Where do people who aren't heterosexual go and feel comfortable when they're experiencing domestic violence? So some of the factors that would contribute, maybe that people might not be in a place where they're moving toward violence, but they also might not be able to get the help that they need to circumvent what potentially may or could come. So what factors? They're the obvious ones, the ones that we all talk about, which are power differentials, inequity between people, relationships, environment, in unequal power distribution. Those things are common theme. Those things are the drivers. However, what happens is the way in which, oh, I got 2 minutes. Wow, cool. The way in which we relate or identify or validate the relationships or the gender expression is probably more significant in what we need to think about when we leave here today around this community. What barriers do people experience either in healthcare? I just mentioned the shelter system. And again, I want to be really careful and say that it's not about a poor shelter system. The shelter system is awesome. We just need to figure out how to find a place for people from these communities. Health services in working with Pride Health, getting in the healthcare system for someone who's transsexual and is in a domestic violence situation, because people really don't even get what that means or what gender they might be relating to, and they don't quite understand the parameters, and then they don't have the backstory about how to work with that person. So in healthcare, it's not so much that there isn't a healthcare system, it's that we need to develop our cultural competence and our knowledge around access, and then being able to serve people in a really equitable and knowledgeable manner. So I think the drivers are the same, but I would say if you took a word away, it would be access, and it would be knowledge. It would be not being stuck in the gender binary, and not being stuck in the heterosexual definition of relationships, so broadening. So that, how'd I do? Oh, excellent.
Thank you. Thank you very much. Phyllis, Marsh, Jarvis?
Thank you. This should be good.
Good luck.
I'm coming from my personal experience. When I think about domestic violence, I think of family violence. And that's what happened to me at the age of 3.5 years old. I was adopted. I was adopted by a family, and they were from the West Indies. My father was just a wonderful man. My mother, unfortunately, had some issues. A wonderful woman. Throughout the years, dealing with this abuse that happened to me, I'm still able to love her. But I think the system failed me, because they placed me in this home, and I think they believed because it was a place where I would be well looked after, which I was. We were pretty well middle class, and I had everything I wanted, but there were problems in there. It was a very toxic home. As a result of that, I was beaten almost daily. My mother had this strap from an old trunk, and one of those old-time trunks. Some people here would know what I was talking about. And it would leave huge welts on my legs, and on my body, which would take a long time to heal. And then if I got a beating the day after that, there were new welts on top of welts. I was also told that the emotional abuse was that I was going to be nothing. I was going to end up in jail. She told me she hated me. All of those things that I had to grow up with. It impacted on me as a young woman. I was a very angry young woman. And of course, when I made choices in partners, even though I was with someone that I considered my best friend, I went from one power structure to another. You know, not being allowed to do things, you can't wear makeup, you have to think like I think and whatever. And I began to feel that I thought at that time that was a normal way of life. When I finally decided to leave, there was such a freedom, but then I would go to another partner that was just as powerful. I speak of that today because I think a lot of times women don't really understand what abuse is. They feel that this is something that I have to accept, and it's from what you experience from young, you carry with you. I then thought that I needed to save the world, so I had a agency, Venka Godsill was a part of that, and it was called Rainbow Women's Support. But from that agency, I got to hear the stories of other women. And the one sad story that I heard, there was a young woman who experienced abuse. She experienced her father beating her mother every day. And when she became a woman and when she got a partner, is that she said if he didn't beat her, she thought that he didn't love her. And that was so sad. but that was her reality. A lot of times in our African Nova Scotian communities, 2 minutes already. Haven't said anything. In the Nova Scotian communities, I think when you're talking about the barriers of violence, is that we have no place to go. Who do we go to? Who do we trust? I think that there needs to be partnerships with the churches. There needs to be partnerships with organizations. I really feel that we need to put some programs in place, but programs that are put in place with the partnership of the people that will be using them. So we don't want people coming in saying, we're going to put this program in for you. You have to know what their needs are. The other thing is that if you're going to give a service to us, you can't get service if you're afraid to come into our communities. You can't give service if already you're prejudging our communities. You can't give good service. That's not going to work. So we need more open services. We need people who understand. We need service providers who, if you don't know me, if you don't know my culture, you can't serve me. I think, too, to be able to have access. A lot of times we don't have access, and we want to know why there's domestic violence. A lot of times it's due to addictions. A lot of times it's due to poverty. A lot of times it's women not knowing their value. We need to really start teaching our young women from very early ages who they are and that they have value. Because once you understand your value, I believe that you become powerful within yourself. And if you're not powerful within yourself, you leave yourself vulnerable to be taken advantage of.
Thank you, Phyllis. Now we'll move on to Debbie Boyd Crowther.
Well, thank you. And Phyllis, I'd like to really honor you for your courage and your determination to say your story. Because much of the work that we all do, it's about reflecting upon our journeys, knowing where we are right now and understanding where we're going, but we need to understand where we're coming from. And we have to name it. And an elder said to me yesterday, we had our men's advisory group from our Two Wolves Men's Intervention Program, the first of its kind in Nova Scotia, yesterday, and I'll talk about that in a minute. But she said to me, you know, you really have to help people name it. Mm-hmm. When you name it, that's when you start to heal. So thank you so much. I want to talk a little bit about, I'm going to be talking a little bit in circles, I think. I looked at the 3 questions and I said, I'm not a very much linear thinker, so I looked at it and then just prayed a little bit and just let it all flow out in that context. So I'm going to talk a little bit about our journey as an agency and how we evolved from doing child welfare work. For those of you who don't know who we are Mi'kmaq Family and Children's Services of Nova Scotia. And in 1985, we came together to provide child welfare and family services according to the provincial mandated Family Children's Services Act. And subsequently, in the early 90s, we really needed to look at expanding our focus to really help families who are experiencing family violence and using the Indigenous process, traditional ways of knowing, cultural relevance, cultural safety. A lot of words that our previous speakers have said this morning are really resonating with me in terms of what I have to say today in the context of family violence and Aboriginal women. So the family shelters opened in the early 90s. We have 2 shelters, one in Cape Breton and one in mainland Nova Scotia. It services all First Nation communities in Nova Scotia. We have shelter services, counseling, outreach. I'm very proud to say men's intervention now. Outreach for men, outreach for youth, and community support initiatives to really look at what does healing look like? How should it be rolled out in the community? So a lot of engagement and participation from our community stakeholders and our elders is very essential in really shaping the direction of our work. In 2007, we restructured our programs to better meet the needs of our families who came to the attention of our agency as a result of our participation in the Canadian Incident Study on Child Abuse and Neglect. And that afforded us the first opportunity to look at the data, not in terms of people who came to our attention through intake and child welfare, and subsequently intervention services were provided, but really take a step back and look at how are these families coming to our attention initially, prior to intervention. So that gave us a very huge opportunity to look at how we were meeting the needs of our families within our agency. And in terms of family violence, we really weren't doing a very good job, simply because our services were not being responsive to the overall global holistic needs of the families that we were servicing, particularly families who perhaps early in the abuse cycle could take advantage of other more proactive prevention services before other intrusive means were introduced to address risk of harm to children. So with that said, in 2007, we expanded and we restructured our programs. We combined the Family Healing Program, which is our shelter and domestic violence prevention program. We are the mandated service provider for First Nations in Nova Scotia, according to our tripartite agreement with the province of Nova Scotia, the federal government, and our chiefs in First Nations. And from that, we combined or married the Family Support Program, which provides in-home specialized services to at-risk families. We combined it with the Family Healing Program, which is our shelter and our domestic violence programs, and we were able to embellish that subsequently a couple of years later with the expansion of community support workers who work in tandem with family support and family healing so that people can access our services at a community level, but that can actually provide an opportunity to be the gateway for more specialized services. So it was a multidimensional approach. Necessity is the mother of invention, and hence, this was a great opportunity, I say, for community engagement, for building trust. Imagine a child welfare program providing prevention, intervention, and shelter services. The very system that was in place in my lifetime, I was born in 1965, and residential schools were still alive and well in Canada at that time. And, the very systems that are in place, and that's one thing we always have to be cognizant about, is that the very systems of health, education, child welfare, social services, policing, even though there's a different veil of support that's being offered to families right now and communities, it's really essential that we have an understanding that the very systems that we have in place right now to be helpful served to strip away relationships not a generation ago. So the hurt is still very much fresh. Our programs continue to grow with great momentum through opportunities of learning and collaboration with health, education, justice on a tripartite level, and these linkages have been critical to nourishing the direction of our work. Collaboration in internal and external capacity building is really important in this particular paradigm, building trust, sharing resources, and I think if you could think about a best practice model, it's about inclusion and an invitation to First Nations to be at the table, not to download a program, but to do a program with rather than for. Our goal is to have our consumers of our programs comfortable with our approach, our initiatives, and our resources, and moreover, to help move beyond survivor mode and toward self-sufficiency and personal empowerment. The Family and Community Healing Program service delivery model is based on integrating Aboriginal values with the determinants of health and wellness, which are powerful factors in impacting the day-to-day realities of our Mi'kmaq communities. Family violence is a community issue, which requires a whole family approach in the healing matrix. I made a reference to the Two Wolves program, which is our Mi'kmaq Men's Intervention program, and that's really a perfect example of community capacity building in which we forged linkages with Bridges program, Bridges Men's Intervention program, and program Second Chance, elders in the community. We have advisory committees within our communities who help guide us in the direction of the work. So the ownership and the investment of people who are using these services is absolutely pivotal to positive outcomes, that it's not a Health Canada project, it's not an Aboriginal Affairs of Canada project, it's not a Debbie Boy project, it's a project for and with Aboriginal people. I want to talk a little bit about spirituality playing a role in the cultural identity, the use of restorative practices such as talking circles and sentencing circles, which bring people and resources together in an effort to repair harm that's been done. Last year, the research project was completed with the Tripartite Justice Committee on Family Violence with Dr. Jane McMillan, addressing Mi'kmaq family violence. And I encourage you to Google that and read it. It's an excellent report, and it's really reflective of people's voices in the forums that were held in Nova Scotia. Overwhelmingly, the participants in this research indicated, and really just validated the direction of our work, that poverty, limited exit options, addictions, and cultural loss are the most significant factors that perpetuate family violence and contribute to underreporting and accessing services, and I'm going to add to that, continuously engaging in services. From this research, we have learned that success requires community design and ownership, sustainable mobilization, and sufficient resources to make choices available that are culturally real and comprehensive. I want to leave you with a couple of words in terms of being a health service provider. Effective service delivery depends on the commitment to cultural awareness and competency, inclusion of Aboriginal people in this process, consideration of alternative traditional methods of healing. So, two things to think about in terms of understanding the Aboriginal experience is culture and healing, and embedded within that is the language and other practices, and the inclusion of kinship networks, the importance of elders. Our challenges, of course, is the lack of sustainable funding, the lack of a national database to collect data in a clear, accurate way that really is a reflection. So we anecdotally know that some of the work that we're doing is being effective, but in terms of measurable positive outcomes, it's diluted because of this lack of a national database. First Nation communities need to take the lead in navigating the direction of services which impact Aboriginal people. Healthcare providers are in a unique position to identify and make appropriate connections to Aboriginal service providers. And this is very important. We're currently in a close relationship with the Maternal Child Health Program, looking at how we can nourish and enrich their resources to start help them have conversations with people about relationships and about culture and about the reclaiming of culture. We're in a period now where not so long ago, there was a deconstruction happening and the stripping away of cultural identity. I think now we're embarking on a wonderful period of time, and I hope I see it in my lifetime, for cultural reclamation, a cultural reconstruction. I want to leave you with these key words: language, loss of culture, reclaiming of culture, holistic healing, inclusion, collaboration, capacity building, whole family approach, balance, medicine wheel teachings, community, and elders. Thank you so much.
Next, we'll move on to Marie-Claude Rio.
So I'm Marie-Claude Rio, and I'm the Executive Director of Réseau Santé Nouvelle-Écosse, which is the health network for Francophones. We're an organization that supports and cooperates with Francophone organizations, working with issues related to domestic violence, such as AGFNE, which is the Jurist Association, and Fédération des Femmes Acadiennes, which is the Women Federation. For Réseau Santé, domestic violence is also a mental health issue, and that is why Réseau Santé is particularly concerned with the issue of domestic violence. In all of Réseau Santé's discussion with the departments and service providers of Nova Scotia, and you will understand this is a common theme, including those pertaining to domestic violence issues, we make sure to convey the Francophone perspective, and we emphasize the need for a better understanding of the Francophone and Acadian language and culture. So whether we are gay, whether we are Black, whether we are Mi'kmaq, I think that we have to emphasize the need for a better understanding. of the clientele. And in our case, we're the Francophone and Acadian culture. Domestic violence issues are also discussed through the various seminars and symposiums that we organize. And finally, Réseau Santé's board of directors includes a representative from the Department of Health and Wellness and Department of Community Services, and which are responsible for transition houses in Nova Scotia. For us, domestic violence is based on an unequal power relation between partners. Victims of domestic violence are isolated and intimidated. Domestic violence can be physical, psychological, sexual, and financial. In this unequal power dynamic, the aggressor will foster a relationship of dependency. Alcohol, drugs, low self-esteem, there is nothing new there. Family history, loss of control, whether related to financial separation or child custody issues, and mental health are all factors contributing to domestic violence. Finally, the victim of domestic violence may not be aware of the resources available in the community. Therefore, the victim has no choice but to remain in a domestic violence situation, and the situation only worsens. And this is particularly worse for Francophones because in the majority of Acadian areas of Nova Scotia, there are no resources available in French for victims of domestic violence, except for Juniper House that offers some services in French in the Southwest region. So in Halifax, Francophone victims of family violence have to travel a certain distance to get access to transition houses where there are no services in French. And we just have to think of the Metro Transit strike and the taxi fares right now that are both prohibitive, and we will never know how many victims stay in a domestic violence situation for lack of travel accommodations. Immigrant women are an even worse situation. Without any social network, they don't know the resources and services available. So no French and no knowing of the resource. Furthermore, some immigrant women will tolerate domestic violence because of the unequal power relation they are used to in their country of origin. Other barriers in seeking and using support services may be the lack of financial resources and low-cost housing for victims of domestic violence and their children. The unwillingness to destroy the family unit for the victim, the fear to endanger the wellness of children, the control of the aggressor, who will often limit the capability of the victim to get help. We feel that there is a definite lack of social workers and psychologists, and this is even worse when you consider the capability to offer services in French and to understand the Francophone and Acadian language and culture. Significant research has shown that even a perfectly bilingual person will lose the capability to use the second language in a situation of extreme stress. It is therefore very important to have personnel capable of addressing the victim in his or her mother tongue. Health professionals should have training on the Acadian and Francophone culture. Workshops are currently offered by Acadian Affairs to government employees, including health professionals. Personnel that speak French should be clearly identified in hospital, and health professionals should make an active effort to publicize the availability of services in both official languages and ensure that people feel equally comfortable in dealing with language of their choice. There should also be more bilingual nurses, psychologists, and first-line staff in all hospital departments, and not only at the women's clinic. Finally, we should do better at identifying persons at risk to become an aggressor and have help and resources available for these potential domestic violence aggressors. We feel that very often we focus on the victim, but we don't offer services and help to prevent aggressors being aggressors. So thank you.
Thank you, Marie-Claude. Now we'll move on to Judy Hughes.
In all seriousness, I think the information you're receiving from the excellent panelists to my right deserves a full day, not to mention 5 minutes. So to do justice to the information and to do justice to the skill sets that we need to work with this population, I think that we need far more time than 5 minutes. Although I did accept the challenge. I, first of all, want to say happy day after International Women's Day. Thank you for inviting me. And thank you for all the fine work that all of you do in the room. We all truly appreciate it. The first question that I looked at, and as those of you who know me, I didn't do what I was told to do. But I did want to answer the first question, and that is my connection. I was born with a crooked back and 2 very lousy hips, which made me a target in school very early in my life. And, but it also taught me very early in my life that isolation brings the predators. And if you're paired and in a group, then you can keep the predators at bay a whole lot longer than if you're in an isolated, vulnerable position. So I learned that very early on in life, and I became a very powerful, in touch with my center and enjoying my life kind of individual. I worked in Botswana with women and children without a language. And this brought me to Calgary. And because I did work in Africa with women and children without a language, I thought I kind of found my niche. So, and when I went to Calgary, there was a job at the Calgary Women's Emergency Shelter in 1977, and I began working with women and children in the emergency shelter, and they were all struggling with the why of it all. Why me? Why us? Why our family? Why? So it was an incredible learning curve for me, and without finding feminism in 77, I might have quit the business altogether, because it was very painful to witness, and it was very hard to understand the dynamics without a political place to put it. So feminism for me was a lifeline. My feminism is rooted in my belief in the resilience and strength of women and children. Also, I believe that male violence against women, emotional, physical, and sexual, is not an option. It's not an option in the family, it's not an option in the community, and it's not an option within relationships for sure. Some of the challenges that we faced, I thought it was important for me, because I've been doing this business since 1977, so I do bring a certain skill set with me. So I wanted to kind of share that skill set, or some of it, 5 minutes, some of it with you, because you need to know what to do. You need some concrete, because these women have outlined the complexity and the overall dynamics extremely well. It's quite a think tank at this table, actually. So I wanted to give you some practical. They're not doing that to me now. Because I'm the last one. So nobody's waiting for me, other than the agenda. Okay, let me get back to what I'm doing here. If we couple this, we need to recognize that all women who are living in a violent situation experience the cycle of violence, the isolation, and the erosion of self-esteem. 3 huge principles within the cycle of violence. If we couple this with a physical or mental barrier, because I've also committed to talk about women living in a violent situation as well as living with disabilities. So if you couple these dynamics with a physical or mental barrier, then we have women in an extremely vulnerable and potentially dangerous situation. The statistics bear this out. 1 in 6 women live in a violent situation. And in the women disability community, this number is doubled. So We've got a lot of work to do there. We've got a lot of understanding to do. We've got a lot of asking the right questions about what you need. There's no generic blanket service that will do all of disabilities, as if we include the cultural, if we include the what else? Whatever different dynamics people bring to their service providers. So one thing is very important. There's a couple things that are very important. Training is extremely important for all service providers. Government personnel need generic, basic training in disability issues and assistive aids, because this is very important for women living with disabilities, and the appropriate response to someone who's been violated. This could easily be rolled into present training modules. Cross-training would build collegiality. Now, I'm talking about service, I'm talking about police, justice, anyone that touches a woman living in a violent situation, and I'm not only talking about physical violence, I'm talking about emotional violence, and I'm talking about sexual violence, and I'm calling it violence on purpose. Because we tend to think that emotional violence, oh, well, what the hell. But emotional violence is the most eroding of our self-esteem, and women live in it for 40, 50, 60 years without ever having it named or without ever recognizing that they are a shell of a person. And they eventually lose their spirit to emotional violence. We need to collaborate. We need to collaborate with each other, and this has been already mentioned. Case planning is absolutely essential, that community services, health, education, that all of the service providers are working together as a unit to support this woman in her needs and given her reality, so that everyone is on the same page, and that's not to preserve your mandate, that's to preserve her health. Because a lot of us are into preserving our own mandate and making women fit into that mandate as opposed to the mandate working for the women. Resources. The dollar is shrinking for everyone and everywhere. Using services already on the ground. I know there's a conversation within the transition house movement. I mean, there are women that are homeless out there being vulnerable and preyed upon. Could we not use the transition houses for homeless women as well? Our churches, our whatever we've got out there, we've got to use so that the services are, because getting new services is not on the agenda. So we have to get really creative, and we have to get really strong, and we have to start yelling and trying to maintain what we have, and but collaboration may help in that from an economic sense. Legislation. We need harassment legislation. We need harassment in the family to be seen as a criminal charge that we can incorporate, because right now the only violence charge when it's in the family is physical abuse. But we need to incorporate that emotional abuse in that legislation as well. Naming it, once again, I want to strongly recommend that we name it, and it's male violence against women. That's what we're talking about. We're not talking about family violence. We're not talking about domestic violence. We're talking about male, as a rule, male violence against women. Because if we don't name it, and if we don't put a political pot to put that in, and I would suggest if we don't have a feminist perspective when we name that we're not going to get the services that are absolutely vital, essential, and critical to deal with this situation. Thank you for giving me the extra 4 minutes.
Oh, thank you, Judy. If anybody doesn't think it's a little bit challenging being here, you're wrong. Anyway, Tabinda unfortunately had to leave, but she did leave me with her speech, so I do want to read this so that you do get her perspective. So this is directly from her. Hello, everyone. My name is Tabinda Sheikh. I work with the Policy and Planning Branch of the Department of Health and Wellness, and I'm also a member of the DHW Diversity Committee. I'm glad to have this opportunity to provide my personal and professional perspective on domestic violence as a Muslim immigrant woman, as an immigrant medical doctor, and a member of the Southeastern Community Health Board and a policy analyst. Before I answer some of the questions, I would like to clarify that Muslim immigrants are a very broad and diverse group with different cultures and beliefs and faith perspectives. My intention is to talk about and answer any questions on the topic of domestic violence from a perspective based on my cultural experience, belief, knowledge, and understanding of Muslim faith and religion. Question 1. I know many women from my community, family, and friends that have in the past or are currently experiencing different forms of domestic violence, such as physical, psychological, emotional, financial, and sexual. Currently, I am working with a few women from my community to identify factors that contribute to domestic violence and very carefully find ways to educate men and women about Muslim religious views and constitutional laws on domestic violence in Canada. I've been briefly involved in the development of the Domestic Violence website, an initiative by the Nova Scotia Advisory Council on the Status of Women. Question 2. Domestic violence happens in relationships globally across culture, race, ethnicity, and socioeconomic strata. Some general factors that contribute to domestic violence include, but are not limited to, awareness of strength, power, and control, physical, financial, etc., acceptance of patriarchal views and practices, learned behavior, childhood experiences, income, socioeconomic status, education, ability, and some cultural factors. Women accepted as a norm. Lack of awareness and knowledge about religious and constitutional rights, cultural models, family pressures about male dominance and control. Most importantly, the religious factors. Male community leaders and men in the community self-servingly misinterpret Quranic scripture to justify domestic violence against women and the family. Lack of knowledge of scriptural interpretations empowering women. I realize that these factors are important, but in respect of time, I would like to talk about the religious factors. In most cases, when the perpetrator is a Muslim, it is blamed on the religion. I would like to bring it to your attention that there is a clear distinction between culture, social conservatism, and religion. Islam is the religion, and the Quran is the holy book that provides guidelines and directives for Muslims. There is no such thing as honor killings. Quran condemns any and all acts of violence. It protects the weak and the vulnerable and holds perpetrators accountable for their actions. It is a religion of fairness, justice, and peace and tranquility. Men and women have equal rights and clearly defined roles and responsibilities, and yet the freedom to choose other roles, like economic freedom for women to earn without being financially responsible to provide for the family. Upon arrival, a lot of immigrant women live in isolation for a long time. They do not have the knowledge about available resources in case of abuse and violence. Even if they do, a number of them are terrified to leave the house alone or with someone else to access those resources due to concerns about safety and fear of harm to themselves or their children. Those who do go to see healthcare providers do not necessarily trust or feel safe to disclose the truth. If they do disclose, these women appreciate the help and support available, but do not necessarily find it to be culturally competent. And that's what we have there, and I really thank Tuba for doing this, and I'm glad that I was able to share that with you. It is an important perspective.
If there are no questions, I just have a couple of things that I want to add. And I've got two more categories. What works? What works in dealing with women that are living with violence is Believe Her, a feminist perspective, protocols and service agreements, case planning, respectful, fair, and polite attitude, accessibility and assistive aids, support services and referrals, collegial relations with service providers, and follow-up. From an individual response perspective, once again, believe her. Get to know her story and name the abuse. Support her in her efforts to explore her potential. Advocate for special needs. Encourage self-esteem. Provide options. Provide information and resources to inform decisions.
Thank you so much to the panelists. Actually, the panelists, we do have, if we have some closing remarks from the panelists before we move into the table discussions.
One of the things I just want to say is that, you know, because of the social breakdown that resulted because of colonization and subsequent assimilation policies, there's been, and there still needs to be a lot of work done. In 1989, the Supreme Court of Canada came out with a number of recommendations as a result of the Donald Marshall Jr. inquiry. And of those many, many recommendations that were made, we still have numerous recommendations that's going to impact justice, issues of self-governance, governance, and issues related to culturally safe and appropriate services for victims and offenders. We still need to look at a whole family approach as well to supporting men, supporting women, and supporting children. I think it needs to be a kaleidoscope of many different lenses in terms of supporting our families. And I think we also have to be very cautious not to adopt a pan-Indian approach and a one-size-fits-all approach to a lot of the families that we work with in Aboriginal communities. Even within Nova Scotia, there's diversity even within our own Mi'kmaq communities. You have some communities that there's so many fluent Mi'kmaq speakers, whereas you may have other communities that, particularly on quite a few of the mainland communities, but there's a resurgence of language happening, which is wonderful. Merdina Marshall, who's an elder in Eskazoni, many years ago when we were expanding our services, particularly with the family support program, and I went to her and I said, you know, what do we really need to look at in terms of the building blocks for this? And she said, my dear, you need to look at language, because language, and there's so many subtle nuances within the language, and it's embedded within the language, and that's what culture is about. So it's important to get to know the person through understanding their culture, but understanding what their immediate needs are, and also as service providers and health, to have a real good inventory of what's out there in terms of Aboriginal services within your community. We don't get a whole lot of calls from healthcare providers at our shelters, and I really want to work on changing that. Thank you.
I just wanted to add that I gave you a lot of barriers that Francophones and Acadians have in Nova Scotia, but there are good news too, so I didn't want to leave you on a bad, or negative feeling. There are lots of tools that are available in French, and I wanted to talk about three main ones. We have the action plan on domestic violence has been translated, and we also have info on the Justice Department website pertaining to that, so that's good. There is also the Parent Information Program that is being finalized now in French. And as you may know, the Parent Information Program is a program aimed at separating or divorcing couples to ensure that there is no domestic violence within the family, and to protect the children first. So that is great, and that is being finished or being almost done in French. So it will be available soon. But first and foremost, and I mean, for me, it's a wonderful tool that is just new from the press. I think it's 1 week old. It's called Be There for Her, Être là pour elle. It's bilingual. And we also wonder how to help women that are victims of domestic violence. We don't know how to. Well, this is the perfect tool for that. It has where to find resources, domestic violence, what it is. Judy said about listening and understanding and naming, well, how to recognize the signs. Am I able to help her? How to help her? How to talk to her? And how to ensure our security. So this is made by the Fédération des Femmes Acadiennes de la Nouvelle-Écosse, so the Women Federation Association. It is a federation, it is bilingual, and it is a fantastic tool that is going to be distributed to as many places as possible. So I just wanted to particularly talk about that one because I think it's very important. Thank you.
We're going to go back over. We've had a new decision by the right side here. Going to go to Jeannie Rokaj.
At the risk of perhaps getting into a bit of a tangle with Judy, which I'm afraid of anyway, because She's a powerful woman, I know this. I just want to invite you to, she talked really clearly about men and women, but just to not lose sight of the fact that the violence is, ultimately between two people. And to understand the other thing I didn't cover was just about families. Our families are more diverse than they've ever been. So recognizing that although we don't have a template and we're not where you folks are in terms of resource and materials, to look for those same signs, but just looking for them in the context of different relationships that you might not have thought of before, or different gender kind of, oh, thanks, Judy.
Yeah. Jeannie, to add to what you're saying, we have to understand that there's a root for the violence. There's a lot of times there's a cycle. So we have to understand that there's a cycle of violence, because if it happens with a parent, or if it happened with grandparents, it just follows through to young people. The other thing is that I'm really, it's important that we get the education to our young people. I know I said that before, and I'm repeating myself, but we want to put a stop to this violence, to this domestic violence, and the way to put a stop to it is to educate at a very early age. That's very important.